Hello, everybody, and welcome to Mouth Matters, open and honest conversations about oral cancer. Dr. Mahesh, are you on?
Yes, can you
So,
hear me?
hi. So today we are speaking to, well, can you tell us your whole name, please?
Yes, it's Mahesh Kumar. What I do is I do head and neck surgery. So I'm a cancer surgeon in London, UK, and also the president of Mouth Cancer Foundation in the United Kingdom. So
Well,
got two.
thank you for all that you do. And we have survivors, caregivers, dental professionals on this call. And there are all kinds of questions I can think of asking you. And then afterwards, please gather your questions, put them in the chat, and we will be sure that Dr. Mahesh Kumar will answer your questions. So can we start with how did how did you even get into the oral cancer field? Was there in a moment that you said, wow, this is what I want to do?
Well, yes. I started off as a dentist, worked uh, but primarily in hospital, but I started off as wanting to be a dentist. And then while I was doing dentistry, I enjoyed the surgical side of dentistry, i.e. there's the gum disease bits and the periodontal flaps and things like that. So it sort of ignited an area that was developing in our field, oral surgery, and cancer surgery within our field needed to be done by someone who had both dental and medical qualifications. So I had to make a decision. Do I go back and do medicine and surgery, or do I stay as a dentist doing local treatments? And I decided I'd, go down the field of doing the double qualification. So it's two lots of degrees, medicine and dentistry, and then train as a surgeon. So it took me like 15 years to get through the whole training.
A lot of education.
A lot of education, a lot of time reading and doing exams. So to get to the other end was quite good. And also, and the work that I was doing, I was really enjoying and trying to make a difference. So I think that's what led me
And
to
in your
cancer.
15 years of education, how much time did you spend learning about how to communicate with patients, especially how do you tell patients you have cancer?
Well, that's a thing I initially struggled with because it's quite a big thing to. You're not taught that particularly at medical or dental schools. You're taught to listen. You're also taught about education but specifically talking about cancer is you do that after you've done your sort of basic training and junior doctor's work and things like that, and then you come to becoming a senior trainee, and then breaking bad news is usually done by a consultant or
Oh,
a senior trainee, and it's you can't just tell someone straight away. You have to sort of give them sort of ideas that the reason why you're here is because it's something serious. And so, but usually you have within the, it can't be done as an individual thing. You have a usually have a team of people like a clinical nurse specialist with you, and to support the patient and family after the.
right. So when I went through treatment for stage 4 oral cancer 27 years ago, there was no team concept. I
Mm.
remember I went to the surgeon and he said, so now you need to start radiation. And I needed to actually find a radiation oncologist on my own. It's unbelievable how it has grown to include, mental health and so much more. All the physical help that you need, the speech pathologists. I mean, that whole team did not exist 27 years ago. So we've come a long way.
Absolutely, yes. When I started, in fact, as you said, there were no specialist nurses to deal with this. There was like they learned on the job, and speech and language therapists didn't have much to do because a lot of patients couldn't properly speak afterwards,
Right.
and had tubes feeding as a standard treatment after radiotherapy and after often mutilating surgery. And everything's evolved realistically over the last 20 years or so. where we've refined treatments and made them a little bit more patient friendly in some ways,
Mhm.
and treatments meaning they can be surgical innovations and also
Well,
radiotherapy.
speaking of innovations, is there anything out there right now that you are really excited about? New innovations that you could tell us about in, the surgical aspect of treating oral and head and neck cancer?
Yeah, we're always innovating. We're always trying to advance the care. I think most people are looking at things like robotic surgery, which is now becoming more the norm, more for ENT type head and neck surgery, but also we're using it as well. We're using patient specific devices and plates, and so manufactured specifically for that patient, which is excellent advancement. Also,
Devices, you mean if somebody needs a new palate or a new mandible, you've got these advances to provide that for them?
yes, absolutely. Firstly, you have the images of the patient's, like let's say for jaw cancer, the images of the patient's jaw. We can actually on the computer um, make the cuts on the jaw on the computer, and then we know exactly the shape and size of the metal implant that's going to be there, which we will use as part of the treatment and surgery. It cuts down maybe 1 hour of previously surgical time, which we were using. So that's sort of big innovation. Over the last 20 to 30 years, we've also do free tissue transfer, it's called, where you take grafts from one part of the body to the other, which 30 years ago was really unheard of.
Right.
So things have evolved and things have got better. And also treatments, which in the past, you know, where patients after the treatment may not be able to talk properly, they may not be able to drink or eat properly, and almost crippled by the surgery and treatment. Now we've got a lot more advanced treatments so that we can actually uh, see patients may go into the public, let's say outside with family and friends, and they may have a small scar, but other than that, they might be hiding the fact they've had major surgery.
Right. So how come sometimes they take flaps from the chest, sometimes from the arm, sometimes from the leg? How do you decide where to take a flap from?
So the most common flaps are, as you said, from the forearm, which is the oldest flap that we do, where we take the skin and blood vessels from there and we transplant it into the maybe the tongue or the cheek inside the
Just so
mouth.
you know, that's what I had.
Oh, right.
I
Okay. Yeah.
had the whole artery taken from my arm as well to feed blood to the graft site, and it worked.
Absolutely. Basically, it can, right in the old days when we wouldn't be able to do that, uh, it almost everything would scar down. And so you've got a replacement for your tongue and it helps you talk. And I mean, you could hardly tell you've had anything done, which is great. So that's a great advancement. And in the old days, we could not replace bone, which was a big game changer. So now we use bone from the leg, which is the fibular bone, which is like the spare bone in the leg. You have a big strong bone, which is the tibia, and the fibular bone is the spare bone, and then we can reconstruct the jaw with that, and we can actually put implants in there afterwards, and then patients can have overdentures or dentures, which is great. So that can again rehabilitate patients, and that's almost the standard of care now for patients with
Right.
cancer
I've
now.
actually had implants in my radiated bone about 7 years after radiation. I've had two implants on the only
Wow,
side of my mouth where I can chew,
wow,
and
well,
they've
that's
been
great.
successful. But one
Yeah.
of them failed on the opposite side. It was just cosmetic,
Okay, yeah,
just so the top teeth don't drop down.
yes. I
But
mean,
it is very interesting that nowadays you can actually have implants in radiated bone as long as you've got, you're evaluated for that first and maybe have hyperbaric oxygen therapy.
well, absolutely. We would make sure that the most important thing is you have very good oral hygiene and to visit the dentist and hygienist. That is above all more than the hyperbaric oxygen, to be honest. But I'm sure that's why your implant worked well because you do need, and it's so much harder when you've got a dry mouth after treatment and your salivary glands have been taken away. So
So
that
is there any way that somebody who's been wearing an obturator for years, is there any way now that that person could actually have a bone graft to replace the obturator?
absolutely, yeah. I mean, I saw a patient today who had the upper jaw removed, so she's got a hole in the upper jaw, and wished to have that, reconstructed. And you can either, if you're not too worried about the teeth, then you can just have a soft tissue reconstruction, just like you had, where the skin's taken from the forearm to fill the hole, so you can eat and drink without food going, into the nose or nasal passages, or you can have the graft from the leg taken with a bit of skin from the leg, and that can reconstruct the upper jaw and then afterwards put implants in that. So there are
Okay, because there
ways.
was Paula on our call who actually asked that question. And also, how do you communicate with patients who are really hard to understand because, yeah, because of the surgery that they've had? Do you write notes to I mean, do they write notes to you?
It can be that difficult, as you said, and writing notes. Certainly, when the patients are inpatients, they've just had their surgery. We give them either an iPad or a pen and paper. They say, "Oh, we ask, are you in pain? Where?" And they'll write it down, or "I'm fine." And sometimes sign language, giving thumbs up, and that sort of generally use signage is useful. But yes, some patients it is difficult to communicate. It's often easier when you see a patient face to face rather than on the telephone. So face to face is still really important, and you get the feeling of how the patient is as well.
And if there's anybody on the call who feels that someone they know might lose their voice completely after surgery, there are voice banking organizations now, right? Where you could bank your voice and then have an electronic way to speak.
Absolutely, yes. I mean, even with Mouth Cancer Foundation, we have a facility where we can actually voice bank. So the patient, if they do have either throat surgery, where it's usually an issue, or even tongue surgery, where they've concerned that they may not get their own voice back, then we can bank the voice, and then later on electronically they can use via computer to digitize that and make it more like they're talking as they were.
Very interesting. Does anybody else have questions for Dr. Kumar? We just put in the chat is the link to voice banking if you're interested in that. So let's see, what else? What else can we talk about that you think our audience would be interested in?
I think that, I mean, certainly advancements, one thing we haven't mentioned, but immunotherapy, it's a big thing. And I think that will be a game changer for people with advanced cancers, which we unfortunately we do see patients at late stage, and once the tumor or cancer is escaped from the, let's say, tongue or the jaw, and it's gone to the lymph nodes in the neck, then it can go to the lungs and bones, other parts of the body. And we've had no answer for that in the past. But now there's treatments called immunotherapies, which are not like old-fashioned chemotherapies. They're more targeted to the actual cancer, and they can be, as I said, game changers and can increase people's life for many years and potentially cure them as well.
When do you think immunotherapy will be available to everyone?
Well, at the moment, we are trialing a lot of immunotherapies, and we are only using them on late stage patients because we haven't got enough evidence at the moment to say that you can use in earlier stages. But it's usually what we call stage 4 cancers.
Mhm.
But we've seen some very good results on that. So it may be introduced earlier on in treatments when we know we can't just, you know, dole it out at the moment because it's just we haven't got the evidence to say, look, this is going to help you as an individual patient. So we just need those studies and clinical trials.
So who decides whether a patient like me, would have surgery first and then radiation and possibly chemo, or whether I do the chemo or radiation first and then surgery. How does that get decided?
There's usually a general pathway for specific types of cancer. So we have what's called an MDT meeting, or multidisciplinary team meeting, every week. And when we have the patient's diagnosis, we have all the scans done, the investigations done, and then we present the patient to the specialist meeting. And amongst all the surgeons, the oncologists, the radiation oncologists, the radiotherapy doctors, as you know them as, and also the radiologists who look at the scans. So when we're all together, along with this clinical nurse specialists who know the patients, we then say what would be the best treatment for the patient. And
Mhm.
often, or as a general rule, oral cavity cancers, i.e., the tongue, the gums, the teeth, i.e., the gums, and the cheeks, they are more surgical. Whereas anything in the throat, going backwards from the tonsils backwards, is usually radiotherapy or chemoradiotherapy. So that's the general rule. But sometimes, as you said, do you general again with the general rule is that we would do the surgery first and then the radiation treatment. Very rarely it's anything other than that.
I suppose if you happen to see that it's a very aggressive cancer, really fast moving, you may want to kill the cells with the chemo and radiation first, and then,
There is a school of thought that you should do it that way, shrink the tumor down, but we're probably going to try, I think that in the long term, immunotherapy to start it off to shrink it down and then do surgery. Ultimately, maybe in 30 years' time, we will just give immunotherapy and there might be no surgery at all, apart
uh,
from a biopsy. That will be the, I think, the game changer, as I said. And that's what we all hope for. You won't need.
how often do patients come to you in the late stage versus an earlier stage?
Um, that's a difficult question. That we do see a lot of patients late because, unfortunately, with mouth cancer in the UK, we not everyone goes to a dentist. So if they routinely see a dentist, then they may be lesions or ulcers or lumps or bumps may be picked up earlier rather than in late stage. A lot of our patients come via A&E, which is accident, or the ED, what you call it, emergency department. They come
Right,
there with an abscess or infection where they've got cancer, or a lump in the neck, which is the other way of presenting. So they're the sort of presentations we see late stage. Some people, if they've got an ulcer or if it's painful, then they may come to see a dentist or their GP, which is a general practitioner in the UK, and then they
right.
get referred in. And in the UK, we have got a service which is called a 2-week wait service. So if the patient or the medical professional or the dentist feels that this is suspicious of a cancer, then they can be referred urgently and seen within 2 weeks by a specialist.
Wow, that's pretty good. I would say that the biggest problem in the United States and probably in the UK as well is a lack of education for patients. That general dentists aren't educating patients enough about the signs and symptoms of the disease, and often, when they do an oral cancer screening, if they do one, they're not educating patients about what they're doing and why they're looking and what they're looking for. So, as a result, patients who already have a sore for maybe 6 months are now feeling too much pain and go to the ER. Or it's all about education. And hopefully, the Mouth Cancer Foundation is doing a lot and can do more in educating patients about the signs and symptoms of this disease in the first place.
Absolutely. Eva, 100% agree with that. We should be educating them every time a patient should come to an appointment, a consultation. That should be a point that you can actually say, by the way, if you ever get an ulcer, a red patch, white patch, a bump that hasn't been has come up recently or has been there for 3 weeks or more, these are the signs you look for. So every opportunity we should take, I think, especially dentists, dental hygienists, dental therapists. There, that's usually the
Yeah.
patients are seeing, them first before a lot of in the UK, a lot of general medical practitioners, i.e. doctors, do not examine the mouth regularly enough to recognize abnormalities. So it's only if the patient comes to them saying, "Oh, I've got a lump which has not been there before," then they are obliged to refer. But ideally, I would recommend that anyone, who any patient should go and see a dentist first, and then or hygienist or therapist first, and then get referred.
Right, absolutely. Well, it's that time where we kind of close this off. If you have other questions for Dr. Kumar or myself, you can always go to the Mouse Cancer Foundation, or you can come directly to us and we will make sure your questions are answered. Thank you all for joining. Thank you, Dr. Kumar, for your time today. And how often, one last question, can people get radiated twice? The answer is yes, right? But differently, maybe.
Yeah, it's very difficult to say because it depends on the dosage of radiation. You can't give high dose in the same area twice because the whole tissue will fall apart. So if you've had a lower dose, then you can give a little bit more. But once you give radiation to one area, you cannot repeat it too often.
Right. Well, thank you again for your knowledge, your expertise, and for sharing it with us all today. And thank you, everybody. Please join us next month for Mouth Matters. See you there.
Bye bye.
Bye.